There were more than 400 emails. So it took me some time. Many of you must have received the answer about an hour or 2 hours back. But I replied almost, not almost, but in fact, all of them. In some of the cases, then the reply was needed because your question was like that. So regarding exam, you don't have to really worry about it. It will be a very easy exam because it is your first exam. So I won't be making it that difficult. For joining for the first time or for those whose last lecture was the first one, they can face some issues, but doesn't matter. See, just go through these PDFs. I've already sent the link to you, and try to perform as good as possible. But do take part in the exam. It will improve your confidence. I'm sending you the link. Now, this is the link where you'll find all the previous lectures PDF. You got it? Now, say regarding this Sherlock Holmes and other books, well, it is absolutely your choice. There is no compulsion that you must read it, but nothing at the sacrifice of your studies. Those books, they were kept so that you develop a habit of it. Many of you very honestly say that you like reading quite a lot. In Mbbs, in medical science study. Let's starting to voice should be okay. Is the voice okay? Putting a filter. Is the voice okay? Just try to log in again. Because if it is okay for everyone, should be okay to you. Say this question, which is better, laptop or tab? Tabs, they are costly, correct? And they have got limited students. So if you have got the laptop, just buy a writing pad. And in writing pad, you have got the choice, Wacom or Yuan. Wacom is costly, right? It will cost about 10,000. That Yuan is about 5,000. Anything is fine. Right? Okay, chalo, let's start. So those who have joined for the if you want to buy either one, then go for laptop, because laptop has got more storage and it is easy to operate even for other things also. And you just attach an external storage, so more than 2 terabyte of storage at a much lesser cost. All right, we move at a we revise the things at a very high pace for those who are joining today for the first time. So that's the YouTube channel. You will be getting all the videos over here also, in case if you miss it. But see the number has dropped to about, say, from 300, it has dropped to half. Right? This is what really happens. But anyway, for all those who have joined today, God bless. So this is on YouTube. You just search for Dr. Bankim Jani and you'll be getting exactly the same videos. The only difference is this is like live where we are studying. You can ask questions because you can unmute yourself at any time. In the playlist, in the YouTube, this is the journal anatomy. That's the playlist where all the lectures they are in the same sequence. PDF, they can be downloaded from there also. Also from the link which I have already given. Right? This is the email on which we communicate. All these questions they were already discussed. So here it is. We talk about the bones. This is cranium. Cranium is that skull part and the face bones, facial bones. You should be able to unmute yourself. Just a minute. Just check it. Can you unmute yourself?
Yes, sir.
Now.
Yes, sir.
Yes, sir. Now we can.
Yes, sir.
So that is the cranium, facial bones, and third one is the mandible. Right? Mandible is for mastication, for chewing properly. Onto this horizontal bone, that is the clavicle, and this backbone, right? The bone which is on the back side, that is the scapula. And scapula has got two important projections. One is the acromion process, and second one, this one, right? This one, that is what is called as the coracoid process. Yes, you have to remember these names. So acromion and coracoid, and this acromion is connected with the clavicle over here. So that's why this joint will be called acromioclavicular joint. Acromioclavicular joint. This is connected to sternum. That's the sternum. So here it is. On one side, the rib, first rib. Here it is. That's the first rib. On front, it is the clavicle, and on the back side, scapula. So we call it thoracic inlet. This is how you see it from the top. These are making the boundaries. And the boundaries we define in the form of medial wall. We have got the anterior and the posterior. Right? That's the triangle. Triangle is getting formed like this. So here is the complete view. We have got the rib 1. That's the clavicle. And this one is the scapula. This is the acromioclavicular joint, which we have already talked about. And this process, that is the coracoid process. The function of coracoid process is where it will be giving attachment to so many muscles, right? And we'll see those muscles when we will be discussing the myology or the details of the muscles. Fine. On to the front. This is humerus, the main bone. That is the main bone of the arm, right? This is arm. And it is connected with a glenoid cavity. This glenoid cavity is shallow. So this is shallow and the head is bigger. So head will be able to roll easily. And that's why the glenoid cavity is shallow, purpose to give the mobility. That's the reason that we can move our hand in the circumduction. That is the entire hand. It can be moved. Legs, they cannot be moved like that because it is packed like this. Right? The humerus, we'll see it today. Right? It is just holding the entire head like this. So there is a limited movement. But over there, stability is important. Over here, mobility is important. So that's the glenoid cavity. Look at it, right? See how shallow it is. But this glenoid cavity, when we'll be studying the joints, at that point we'll find that there is cartilage also. It is not like that the bone to bone, they are directly talking with each other. No, it is not so. Right? There would be always a cartilage in between, so this will be giving the buffer, right? So that they don't rub against each other. Otherwise, these bones, they won't be lasting for the whole life. So here is coracoid process, acromion process, clavicle, manubrium sterni, and this process, lower process is called the Z-fold process. And that was for your practice. Over here we talked about ribs. So all the way ribs are 1 to 12, right? There are 12 ribs, out of which top ribs, that is 1 to 7. All the ribs from 1 to 12, they are connected on the back side. On the back side, what is there? There is spine, right? So vertebra. So everyone from 1 to 12, they are connected on the back side from the vertebra. Which vertebrae? Obviously, this is forming the thorax. So all the way from T1, T2, T3 up to T12, right? Simple. So they are connected with the thorax. So T1, this is the thoracic 1 vertebra. Above vertebrae, they were related to right neck region. So they were all delicate vertebrae. Now the thoracic vertebrae, they are becoming bigger. Right? As will go down, they will become bigger and bigger. Bigger in what form? Bigger in the form of their bodies. Their body will become bigger. Their transverse processes, they'll be more strong, right? Because they'll be handling bigger and bigger muscles, which are responsible for the movement of the back and holding the entire body straight. Mind well, this is the vertebra. Muscles are attached even in front and the back, right? Even in the front. So front means if you want to see those muscles, what we have to do? We have to open the abdomen. We have to remove all the structures of abdomen. So entire digestive system, kidneys and everything you remove, and then you reach to the spine, and there you see the muscles. The major muscle, which is called as the psoas major. You see that muscle, psoas major, right? So that psoas major, which is like a core muscle, which is giving stability to the body. And that's the whole thing, right? I'll as the time will come, I'll even draw it. Another important thing, that ribs from 1 to 7, they are called as true ribs. True ribs means their one end, the back end, is connected with the vertebra, and the front end, it is connected with the sternum, not directly. In between, there is cartilage. Over here, there is cartilage. All right, even if there is cartilage, but it is connected, right? It is talking 1 to 1, right? See, 1 to 1. On the backside, vertebra 1 and connected to sternum 1. On the backside, 2 connected to sternum 2. So individually, we are getting connected till number 7. So here is number 7, which is coming all the way and getting connected. So they are called as true vertebra or true ribs. Rib number 8, rib number 9, and rib number 10, they are connected to cartilage of 7. So here is 7. Say they come here, they come here, they come here. Right? So that's why this will be, they are called as the false ribs. They are called as the false ribs. Right? This is a very common question, even in Viva, even in exam. I'll be asking this question also, like paper leaked. 11 and 12, rib number 11 and 12, these two, they are not connected on the entry aspect. They are just connected to the posterior one, right? T11 and T12, they are connected, but they are floating ribs, right? So their anterior ends, they are not connected to U1. So they are called as floating ribs. We'll talk about this part. And this is the, from the back side. On the back side, this is how we see the scapula. See the floating ribs. This and this. See there that they are connected to T11 and T12. Right? So here is the back of the scapula. The projected portion, the moment you take your hand, you touch your back and you'll be able to feel on the back side the first bony transverse area, this area, which is like this, right? That is what is called as the spine of the scapula. Spine of the scapula. Irrespective of whether the person is fat or thin, spine will always be fat. Just by normal pressure, you'll be able to feel it. This is important because the muscle which is attached above will be called as supraspinous. Supra means above. And below, that is the infraspinous. Regarding all the chest compression, rib breaks, the cartilage, well, it can be anything. But most probably, ribs break. there is an angle. When we'll be learning about the pathology, there is an angle at which the rib can break easily because that is the angle. Ribs are flat. They are like putty, like thin putty, which is going like this. So at the curvature, they are the weakest. So it depends upon what type of compression. Right? Say, for example, when someone is driving and then there is accident, then the heart, right? Straight away, the ribs which are in direct contact, so they break from that angle because it is a curve. And when this angle is pressed, so yes, obviously it will break from the point where there is a maximum curvature. So this is where it will break. So that is the spinous process. So on the back side, we have got the spine of scapula. Above is supraspinous, below is infraspinous. Infraspinous, we can say is fossa. Fossa means that khadda, which is over here, right? Or which is below, right? There is like an area, right? Which is just below the spine. Then the muscles will be connected over there, so we'll be calling it supraspinatus or infraspinatus muscle. There would be nerves also, so we'll be giving them the same name. Right? So easy. So in anatomy, the names are always given with some thought or idea about it. The names are never given randomly, and one name will not be repeated. Right? It is the same name which will be given. Say, the muscle which will be over here, we'll be calling it supraspinatus. Nerve is there, artery is there, vein is there. Everyone will be carrying the same name. So that the moment you hear the name, that impression would be created. Yes, they are at this function. Correct? But there are so many names to remember. Doubt about it. This line, right? This spine is very important from the surface anatomy purpose. Because from surface anatomy, you really can figure out that what is inside. Out of which this angle. Now, if you try to feel in yourself, say when if you are flexible, so then you can just pull your hand and you'll be able to feel this inferior angle of scapula. Else feel it in someone and you'll find that that is also pretty prominent. It will be carrying some. So we feel inferior angle of scapula. You draw a line and then where it crosses, this is an important point. But this is how surface anatomy is. Say in during the auscultation, I'll tell you that anterior to the chest, right, where you put the stethoscope. Where should you really put the stethoscope? There's a full chest. Right? So there would be one aortic area. Name itself tells aortic area. That means just underneath there will be aortic valve. We are interested in that valve. When it closes, is it making sound? Yes. So we want to hear that sound. So that is point where the aortic valve is there. Where is pulmonary valve is there? So pulmonary valve is closing. So we want to go to nearest to the pulmonary valve. So that area will be called as pulmonary area. Similarly, there will be a tricuspid area, and similarly there will be the mitral area. So once you know these areas, so you'll be having that picture that, okay, this is how the heart is there, right? And your description would start accordingly. Right? Because the nearer to the valve, better is the hearing. And then with the adjustment of stethoscope, right, with the diaphragm, which is a big surface, and if you invert it, right, you rotate that, then on the back side there is bell. Bell is to be placed like a feather touch hand, very delicately. You just put it very lightly and then you hear some sounds. Those sounds, they will be muffled if you apply the pressure. Right? You will see all those tricks, that how to listen to those very faint sound, because that faint sound will change your diagnosis. So that's humerus. We talked about it. So these are the cartilage which we were discussing. Previously, they were all graphic images. This is the real body. So this is how when you'll be dissecting the cadaver or you'll be watching the cadaver, it will be like this. There will be subtle difference between the bone. So that's the bone and that's the cartilage. You just can't miss it. So this junction is called as the costo. Costo means chest. Chondral Chondral means cartilage. Junction. So this is what is called as costochondral junction. Now it is this junction where the movements they can occur. As the age increases, right, they fuse together. So then there will be limited movements. That's why the chest won't be expanded as much needed. Right? So gradually, as the age increases, you'll find that people become weaker and weaker. That they say that it is the aging process. I have mentioned that in many of the emails that this is the right time to start the exercise. There is nothing like it because of exam pressure, you stop the exercise. Never ever. 15 minutes, koi bhi nikal sakta. 15 minutes, that's not much. Right? So here it is. These are the two reps: 1, 2, 3, 4, 5, 6, and 7. And this is how we see the things at an angle. Point to be emphasized in this case that it is this glenoid cavity, right? Glenoid cavity, that is where the humerus will be connected. So humerus is not connected with the rest of the body by any other bones. Function of clavicle to keep the hands on the side. There is one condition which is called as the cleidocranial dysostosis. Right? Don't remember the name right now, but just consider that it is a congenital condition in which the clavicle is not developed properly. So if the clavicle is not developed, this whole hand that will be emerging from front. So both the hands they will be coming like this. They will be coming from front. Right? It is this clavicle. It's dysostosis. There is abnormal growth or there is no growth. It is unable to keep the hands on side. So that's the importance. In pathology, what if it is fractured? Immediately, instead of hand like this, right, you find that shoulder is moved like this. Right, so that you know that is it's injured. Here it is, the fracture. What type of fracture?
Recording in progress.
How many fragments are there? All those things, right? But just this is the fracture. Right? The fractured piece has even dislocated. When we write fracture, we will be writing it like this, hash, like fracture. Here also there is fracture. These are the vertebrae: cervical 7, thoracic 12, so 12 pair of ribs. Lumbar are 5, sacrum 5, pockets 5. But so the total 33. But when you dissect, you'll find that sacrum is usually fused. Right? Sacrum is fused. So all these 5, they are working together as one. It is just one bone. And in pockets also, that is what is also called as the tailbone. Tailbone. So there also its components are fused. So actually, we'll be getting 26 vertebrae. This is theory. That's the theory. Practically, then axial and appendicular region, very, very simple. Arms, right? They are the appendicular region. Axial is the long axis. Right? So which bones are in upper limb? All the way starting from, say, this scapula, humerus, and medius ulna, etc. All are part of the axial. How about legs? Hip bone, two femur, tibia, fibula, and all the tarsals, metatarsals, is in the favor of, again, the axial. Central axis, that is sacrum, all the vertebrae, these ribs, right, head and neck, that is all in the center. That is part of the axial system. Here we are diving deep slightly into the humerus. In humerus, there are two prominence, tuberosity, right? See, जैसे in movies there is like छोटा गुंडा, बड़ा गुंडा. Right? So here humerus is छोटा गुंडा. Right? So that's why its prominence, they are also a bit small. Right? There are prominence there. That is part of axial. So over here, just focus first here. I'll talk about it. Right? So over here, the humerus it has got that tuberosity, right? But when we will go to femur, the femur is the big bone, much bigger bone. So there the prominence is still more. So we'll be calling it trochanter. Right? Tuberosity is like chota gunda, trochanter is like bada gunda. So in trochanter you'll find such huge prominence. Reason, these bones they develop by the principle of traction, pull. Right? If some area is getting pulled, so it will become bigger. Because it will be developing like that. Right? So obviously the leg muscles they are more powerful. So there the prominence is their ridges. They are mammoth, huge one. Then how to differentiate between the bones of male and female? Well, from the muscular point of view, because of the testosterone has got the direct effect on the muscle, right? So it gives very powerful pull. So if it gives powerful pull, obviously all the ridges, markings, trochanters, tuberosities, everything will be very prominent. Right? We'll see those bones. So female bones, they are usually considered as there are less markings. There would be trochanter, there would be tuberosities, but it is not as powerful and strong as compared to the male bones. Right? So this is humerus. There is greater tuberosity and the lesser tuberosity. Greater tuberosity and the lesser tuberosity. In between there is ridge. Now in this ridge, because this ridge is between two tuberosities, we'll be calling it intertubercular sulcus. Whenever we say sulcus, we can say it is like a groove. It is like a groove. But this groove is very important because over here, there will be the biceps, right? Biceps, Y, two. There is one is the long head, second is the short head. So it is that long head which will go all the way, it will go towards it. Correct. It's correct. Right? So because it will be passing through the joint, so that's why when the bicep contracts, right, it will really make it move. Right? The exercises, when you do it with this thing in mind, you immediately know that why the stability of the scapula is needed. Because this will go and it will be connected over here. Over here, there would be the triceps. They are getting connected to scapula. Correct? So if the scapula is stable, and then when you do the exercise, so that means it will be focusing only on that specific muscle. If someone is lifting the why they say form is important. Someone is lifting the weight, but if his whole shoulder is moving, it kills the purpose. Because if the whole shoulder is moving, person is unable to lift, and then they say lift like this. What is that? Scapula is moving. If the scapula is moving, no way. No, now we cannot go back. Sorry, we cannot go back. It has been told very clearly that you need to come on time. Right? This, let me take a break of just 30 seconds to tell about it. How can you send mail that please start at 10:15 or I understand, but in the benefit of everyone, 250 people, right, we cannot go back. Anyway, what we can do is, once we complete, right, you go through the PDF, send a mail to me. I don't mind explaining if there is any doubt, but we can't do that right now. And next time onwards, we'll be starting sharp at 2 minutes past 10. Yes, I'm getting few of the emails also. But no, we can't do that. I'm sorry. So here it is. This is the humerus. Right? As we go down, so this is your elbow. That's your elbow. This is the elbow. In elbow, try to feel. Right? Try to feel. So try to feel from the top. That means you are tracing the humerus. Right? Tracing the humerus. Don't try to feel from your forearm. Try to feel from the top. As you go down, just feel, and you will come across these important prominences. This. They are called as the epicondyle. So they'll be on the medial side, that will be on the lateral side. So the bone is like this. That's the reason the bone is like this. This is the shaft and it goes like this, and it goes like this, and then it forms. Right? So this and this, they are called as the epicondyle, medial side, lateral side. And with that, there would be connectivity of these two bones, they are coming up. That is the ulna and the radius. Radius is on the lateral side. We take the pulse, that is the radial pulse, right? So that's the radial pulse which we take. So radius and the ulna. And this is forming the elbow joint. There are so many other things in this, there is, right? Capitulum, all those names, there is specific fossa. Right now will not complicate the matter. Just understand this is like elbow joint. More in detail when we'll be actually discussing the entire elbow joint. Okay. The concept of bursa. Bursa is like a cushion, fluid-filled bag. Fluid-filled bag, wherever there is any of the pressure, so that bursa would be placed. The best bursa, which is called as the student's elbow, right? There is one bursa which is over here. Right? So we have got the habit of sitting like this, right? Studying like this. So then constantly, right? And it takes years together, right? When it keeps on hitting like this, so then starts the pain. If you press, you get the pain. That is what is called as the itis. Itis means bursitis, bursitis, inflammation of the bursa. Whenever there is inflammation, the cardinal signs are pain, so that you don't lose that organ. Inflammation, so that it is a visually, it tells this thing has become red. There is increasing blood supply because you need to fight out the inflammation. You have to remove that, right? And there would be collection, fluid collection, because it is like a byproduct of the inflammatory process which is going on. All those rubor, this, that, lack of function, all these are, that would be the first chapter of pathology, and we'll be discussing pathology. But the idea is, inflammation is a defensive mechanism. Elbow bursa inflammation, the reason of tennis elbow is different, right? But yes, it is the bursa which is into that region. Any continuous movement, right? Continuous movement that will lead to this bursitis. Same in case of even lower limb also, right? When there is plantar fasciitis. It happened to me about 3 months back. Excessive running. Yes, it was that 100-kilometer race, and after that, right, that pain starts, right? And it lasts for some time. But then there are some very simple things. See, I can say this is a golf ball. So whenever you are, say, working, you just put this thing on floor, and that's how the feel is. And then with pressure, you roll onto that area. This is one of the very fine thing to keep your arch of the foot in its proper shape. And so this is okay. So all this is part of, say, trochanteric notch, coronoid process, olecranon process, etc. That is a part of the elbow. In between, this is crucial. In between, say, one bone and two bones. Wherever there are two bones. Similarly, once you learn this, you see this is a membrane which is between two bones. So membrane. Osseous means bones, and interosseous, that is between two bones. So between radius and ulna, we have got that membrane, right? This is a membrane which would be pierced by so many nerves and arteries. Why so? Some of the arteries which will be going on the back side, and then they pierce this interosseous membrane, they come on the anterior side. So that's what, but what would be the disadvantage? Because that artery is coming very close to that bone. What if the bone is fractured? If the bone is fractured, that artery is also damaged. When the artery is damaged, it can lead to so many complications. But when the nerve is damaged, it will lead to, because it is like a wire. The wire, if it is cut, so then it won't be able to supply to the next electronics or the next gadgets which are connected afterwards. It means that if the nerve is damaged, so then whatsoever the structure it is supplying beyond that damage, right, they will all get paralyzed. So that's how the clinical correlation which we'll be learning, that what happens when there is fracture of the shaft of humerus. What happens when there is Colles fracture? Colles fracture is wrist fracture, when the fall is on the outstretched hand. What happens when the elbow is damaged? Which nerve will be involved? So once you know these things from the position, because it is so simple, there is flexion, there is extension. In case if anything goes wrong to this flexion component, so then extensors will be working. The person won't be able to move his hand, right? Similarly, this is flexion, this is extension. So if the hands have become like this, so that means extensors are not working and taking the fingers to normal position. Nothing has happened to flexors, right? But because extensors, they are not pulling, they are remaining like this. So from the hand position, you'll be able to say which nerve is damaged, right? This is what is called as the clinical correlation. The questions which were asked about USMLE, etc., this is the pattern. They won't be asking, okay, tell me the course of radial nerve. Tell me the course of brachial artery. No, they won't be asking you this question. Very rarely. But when they say anatomy is asked, yes, it would be asked that, okay, this is the situation. Patient fell from the balcony, but then there was a tree and he tried to hook that tree, and in that his arm was pulled, and after that he is having that severe pain into the axilla which is radiating. So that's the thing. What is that? The brachial plexus has been pulled, and after that position. Or when the baby was delivered, right, the shoulder was delivered first. Normally it happens like head comes first and then the shoulder is twisted. But instead of that, what happened? That shoulder was in front. There was no other way but to take the shoulder out. It means the hand was pulled. When the hand is pulled, again the same thing. Excessive pulling of the hand. That means it will be excessive pulling of the brachial plexus. Right? Even if you don't understand it right now fully, which cord, which, no worries. Right? We'll be learning it after we learn all the proper cords and everything. But we are talking about starting the spelling. It is brachial plexus, right? Brachial plexus. Plexus means group of nerves which are into the neck. For the brachial plexus, even in my other lecture, you will find there are two ways you can remember. Ram, To, Do, Chala. Right? This is how we used to remember. And someone said, sir, there is another full form. Remember to drink cold beer. Right? The last is branches. So he said, remember to drink cold beer. Well, both of them are correct. But this is where you will be learning root, then trunk. Trunks will be making those divisions. Divisions will be making those cords. And from those cords, the branches would emerge. This is like a complete circuit. Once you'll understand the circuit, because you'll be supplying specific muscle, you'll find, obviously, if there is any damage to the trunk, everything would be affected. Right? It is like a wire. It is like a wire. If this is the main wire, and then this is dividing into two, say, let's say our house, say, room number 1 and 2, and room number 3 and 4. Then it is dividing like this: room number 1, room number 2, room number 3, room number 4. Right? So where if the cut is over here, entire electricity gone. If the cut is over here, room number 1 and 2, they are gone. If this is the point of break, remember room number 1 is gone. If this goes to like this, right? Let's say this is going to washroom, and this one is going to, let's say, our central overhead light. So if the connection is gone over here, that means that light will be over. And it is what obvious. If you remember this, you have learned brachial. It will be exactly in the same style. So once we learn the whole brachial plexus, normal, and then we'll start putting that why the pull will be at that point, because there has to be a reason. Right? No one will be going surgically and then cutting that posterior cord. No, it cannot. It will be damaged with some other damages, because these cords, they are well protected. But when there is excessive muscle pull, then it gives the damage. And the damage is either the break of the bone or some compression. Right? All those things. Yes, it is like a circuit. It will be like a circuit. Now here comes radius ulna. So radius ulna done. Now we are on to the wrist. onto the wrist, right? You should be able to feel a very pain point. This is the radius. You trace the radius, and at the end of the radius, right, you try to press. You find a very pointed thing. If you press more, you get some pain also. Right? You get some pain. That is styloid process, right? Styloid process, and it is that styloid process. So from lateral side to medial side, will be following, right? These four bones, and in two rows. So this is first one is scaphoid, right? That is the scaphoid. Then so scaphoid is boat shaped. Then comes the second bone. So I mark. So this is yes. So this is scaphoid, right? This is unit, half moon shape. Then comes triquetrum. This is the bone, and on that bone overlapping is the pisiform. Yes, in your email when you said that third and fourth bone, yes, triquetrum and pisiform. So we are watching right now from the front. So here is the triquetrum, and on that there is pisiform. So obviously they both will be overlapped, right? So that is one row, and then comes the second row. So once again, we'll be starting from left to right. Trapezium, right? Trapezium, trapezoid, capitate, and hamate, right? Now, the impression which you are watching over here, it is the hook of the hamate. Hamate means hathoda, right? So it will be hook of the hamate, which is winding around because it will be connected with some important muscle. Similarly, capitate, it is a big one, right? So it is giving attachment to small muscles. So thus, these are the four. 1, 2, 3, 4, and 5, 6, 7, 8. Lateral to medial, and this is the proximal row, and this one will be the distal row. Correct? So that's where we say she looks too pretty. Again, back. Try to catch her. So they are called as the carpals. Carpals. Then comes this. So these are this one, this forming the palm. It's forming the palm. So they are called as the metacarpals. Metacarpals. And then comes the finger. That was a very cute email. I don't remember the name, but when you say nahi, thumb, so there are 3 phalanges, 1, 2, 3, right? So that was fine, and definitely whenever in doubt, I don't even think about it.
I asked that doubt.
That was good. But I'm happy for that you clarified it. What if this blunder is made in exam? He'll shoot you. Examiner will shoot you. Jail ho jayegi chalega, but how can someone say this? मैं ऐसा नहीं करता. Well, this is good. So remember that is forming the palm. You are honest, huh? In front of everyone, you say, I asked this question. Good.
Sir, I will not forget that now.
Huh?
I won't forget it now.
Yes, you'll never forget. Chalo, let me tell you something interesting. What name should be given to this joint? The joint which is between, this is the metacarpal and this is phalanx. Because digits, they are called as the phalanges. This is metacarpal. So it will be called as the MCP. MCP is metacarpophalangeal joint. Correct?
Yes, sir.
Metacarpophalangeal joint. I mean, sometimes in radiology, when we are right, you say that there is injury in the third MCP joint, however, DIP and PIP looks normal. And people say, "Arey, yaar, obviously, this is like those non-medicals, they should not know what we're doing. Right? So this is the metacarpophalangeal joint. What name should be given to this joint, which is between phalanges?
Interphalangeal joint.
Interphalangeal joint.
So what name should I give to this?
IP something interphalangeal.
That is also interphalangeal. So this is also interphalangeal. This is also interphalangeal. Now, how do we differentiate? One joint is near, one joint is far.
Proximal and distal.
Proximal and distal.
DIP, and this would be DIP. Proximal interphalangeal joint and the distal interphalangeal joint. So when I say that, okay, this is the hand, you have to mark, if this is marked, right, this joint, right, which joint is this? One word.
Proximal
Interphalangeal joint.
interphalangeal joint.
PIP.
EIP, and this is thumb is one, so, and this becomes two, so this is nine. Second, EIP. Easy.
Yes.
So that way, the moment you say, immediately the whole picture will be in front of you that what exactly are we talking about. The medical description, it has to be like, even if you close your eyes and if someone is speaking, right, the entire picture should come in front of you. That's great. We talked about this. This is for the division. Yes, these are the fingers. That was the palm and the thumb. Thumb has got two fingers. This image for practice. This is the orientation. The vertebra. Right? Now the vertebras, they are like, yes, you can record problems. Right? So over here, so if I am the vertebra, right? So then these are my transverse processes, and these transverse processes, they will be holding the ribs. Record karo, but focus right now on this. So that is the vertebra. This is the body of the vertebra, and this is the spinous process. So where is spinous process? Spinous process, now you go back and all the way from the neck start palpating. Palpating means feeling, right? Go back. Those prominence which you are feeling all the way into the center, they are the spinous processes. So from side, if you see, from the side, this is the vertebral body, and then this is the spinous process. Another vertebral body, this is the spinous process, right? And this is where there would be intervertebral disc, right? And when they are dislocated, then that goes deep, right? But this is how it goes. So here, this is the lateral view. Now you know the lateral. We are watching from the side. So these are the spinous processes, and then they are connected. And then there is a structure, right? There is a structure which is connecting these spinous processes. So what would be the name of that structure? What should be the name of that structure?
Intraspinous.
आगे बोलो, तो सबको पता था. That is the, and not intra. Intra is inside.
Interspinous.
Interspinous.
Ligament. Interspinous ligament.
Interspinous ligament, because this is between the bones. So
Bone
between
to
the bones,
bone.
ligament. Muscle and bone, it is tendon. Shabash. First class.
So the disc between two spines, which you showed, that is also ligament.
कौन सा बेटा क्या बोला?
Sir, you told the structure which is disc between two.
अच्छा अच्छा disc. It is
Yes, sir.
intervertebral disc, right? There is no connectivity, right? This is one vertebra. On this, there is second vertebra. In between, right? In between, there is a disc. Disc is like a cushion. It is like a cushion.
So, sir, what is it made up of?
Cartilage. It's made up of cartilage.
Okay, sir. Yes, thank you.
All the bones. Just remember one simple thing. All the joints in between, everywhere the cartilage is inserted. because cartilage it can grow, right? And it is a very fine structure, right? And it is very tough, so it can give good protection. So that's
Yes.
why it will always be there. But the taklif part is when this is dislocated, so it will start pressing the nerves and everything, and the pain will rise.
So that is called the disc bulge.
Yes, that is called as the disc bulge, or the technically speaking, herniated disc. It is called as
Okay,
the
sir.
herniated disc. This was my dissertation, right? MRI of intervertebral disc. So where the entire focus was, the entire thesis was written only on this. And in this, one of the very interesting thing is patient comes, right? Arey sir, bahut dard ho raha hai, very painful, very bad. Chilla raha hai, right? Usually those he will go to some general practitioner, right? Or many times people are doctor by themselves. They'll take some painkiller. Now that disc, it was protruding and it was trying to pinch that intervertebral foramen. So when that foramen is touched, right, when that nerve is coming out, you see that anterior and posterior roots are there. So when it is touch and go, so that nerve is very irritated. It will give severe pain. Painkillers taken. After some time, patient would say, now there is no pain, I am happy. What really has happened is that the nerve which was coming out, now the disc has completely locked it. It has completely locked it. Now there is no relative movement between nerve and the disc. There is no relative movement. If there is no relative movement, then there is no pain. Now this is a very wrong thing, because when you take the history, because the next stage will be the nerve would start compressing, and as the nerve would get compressed, it will lead to all the clinical neurological signs and symptoms: tingling sensation, muscle, hand becomes weak, muscle mass is lost, and then gradually it will lead to paralysis. Right? So when you take the history, that's why history is so crucial. That when you take the history, you see previously there was severe pain, but pain was like off and on. Right? It was increasing by the movement. So if the person moves, so then that disc it pinches. Once again, he takes rest, then it is fine. Painkillers are taken. 4-5 months passed. No MRI, no CT scan, nothing was done. And then one day patient tells, now there is no pain. Now, usually during this time, you will encounter such patients. That patient is taking some churn, right? Patient is taking this, that, all those alternative things, and then they get the credit. Dekha, humne pain kam kar diya. Right? These doctors, they are unnecessarily cheating. फालतू में CT and MRI, right? इतना खर्चा देगा, हमने एक पुड़िया दी, ठीक हो गया. ठीक. That patient comes. That something is happening in the hand. साहब झंझन हो रहा है, right? And that thing is not going. Immediately you know that this is nerve compression. You order for the MRI, they'll say 8,000 rupees. ये doctor लूटते हैं. There is no way one can identify this nerve compression without doing MRI. So it happens. When you'll come to clinical practice, it would really happen. But when you show them that, see, now this is really happened, then they understand. आती है किसी में तब भी अकल नहीं आती. Till then, at times they go away. अरे ये तो इतना बोल रहे, जाने दो, नहीं करना. सर घर में शादी थी, इसलिए आज अभी MRI नहीं करना, 1 महीने के बाद आएंगे. Happens. After 1 month, they'll come in emergency when the entire hand is paralyzed or the leg is, depending upon where the compression is. And then it is to that level that you might have to go for operative. There's no way conservative treatment. So when we'll be discussing this, I'll show you all those cases. Right? More than 60 cases they were there of various intensities. Huh? Okay. Right. So these are the ribs. These are the ribs which are connected to the vertebra. Ribs are connected at 2 points. One, at the body. Ribs are connected at the body. That is from where it would start. But while going out, they will also be connected to this, and this is called as the transverse process. So if this is the body and these are the transverse process, so rib would be connected to the body, and while taking a turn, they will also be connected to the transverse process, and then they will go forward. Right? So there are 2 points when things are connected like this. Right? So this is one point where it is connected, and this anteriorly it will be connected, and over here, so this is the central point from where the ribs would be. How smart the thing is. It will be like scissor, right? So there is one central pivot area. So from that pivot area, right, the movements would be occurring. So there will be 2 type of movements, because when you inhale, right, the size of the chest should increase. Size of the chest should increase. So ribs, they lift the chest, and at the same time, ribs will anteriorly. So there will be increase in the anteroposterior diameter and the increase in the side diameter. That is the transverse diameter. So when the chest is lifted, so it will increase in the sideways and it will increase in the anterior. So that anteriorly kya tha? Manubrium sternum. So that sternum lifts. So over here, we are lifting the scapula also, right? Scapula is getting lifted. So what would be the name of that muscle? Levator scapulae. So there will be one muscle who will be lifting the scapula. So when the scapula is lifted, entire chest is lifted. So there will be one muscle lifting the scapula. And we named it as someone who is elevating the scapula. So levator scapula.
Your voice is not clear.
Don't worry. This is, say, these are, just understand the importance. Right? All these things will be coming in tremendous detail. Yes, there are, as you asked, internal and external intercostal muscles. That's right. Costa, we said that costa is chest. So there will be muscles which are in between. Right? There will be muscles which will be in between. So we'll be calling these muscles as intercostal muscles. Right. I was trying to tell you the name. Say levator scapula. Scapulae. Levator means elevate. Elevate means lift. So the muscle which will be lifting the scapula, that is levator scapula. Right? So I'm just trying to introduce few names so that you become slightly comfortable with that. Right now, in anteroposterior diameter or transverse diameter, what is the bucket handle movement, what is the pump handle movement, all those things will come, because this is the core. At that point, if you ask me that how the ribs are connected, तो यार फिर दिमाग जाता है, right? It means simple. One point, it is connected to the body. In the second point, it is connected to the transverse process. Right? But if you remember this much, enough. So what name should we give? This is important. So costa, that means ribs. Connected to the vertebra, the costovertebral joint. So this means we are talking about body. So when it is connected, so this point is called as the costovertebral joint. When it is connected to the transverse process, so bindas transverse se likho na, so costotransverse joint. How interesting. Right? So when we talk about costovertebral joint, we are talking about the body. When we say costotransverse joint, we are talking about the ribs which are connecting with the transverse process. So now this picture should be crystal clear that this is the body, ribs will be connected, right? Then we have got the transverse process. So while going forward, rib will say hello to those transverse processes also. So costovertebral, costotransverse, and then the rib will go further anteriorly, right? True ribs, so they will be having their own cartilage, which will be connected to the manubrium sternum. 8, 9, 10 false ribs, so they will be connected to 7, right? So that's why when we see our chest, right, it becomes like this. Chest becomes like this. So this is the area, right, where the 7th rib directly connected, 8th here, 9th here, 10th here, 11th and 12th they are fusing, right? So that, and this is called as the costal margin. Costal margin. It makes sense? Costal margin. The margin. Same aspect seen in slightly different angle. this. Moves. This is a rib, right? This is a rib, and this one is the vertebra. That one is the vertebra. Here is the body. This is the body. And as the vertebra starts, this is one body. This is the second body. Now, as this is the body, here is the rib. Right? Here is the rib. So this is the formation of first one, where it is connected to body. So that's why costovertebral joint, CV. And then here is the transverse process. This is spine, right? This one. So this is the transverse process. This is the transverse process. See, this back side, they are the spine. So let me draw entire thing. Here is the back. These are spine, and then see this portion, this one. So that is where it is connected to the transverse process. See, it is one. Here it is. This is the best angle. This is the best angle. Here it is, costovertebral, and as it is going, see this costotransverse. And these are intervertebral discs.
Sir, in the previous diagram, where was the spine located?
This is the spine.
The one which you have marked, right?
This which I have marked. This is spine. This is spine. This is spine.
Okay, and the small bulges which we are seeing, like spine to just bulges, they are transferred, right? Okay.
But these transverse processes, when we'll be studying vertebra, we'll find that these transverse processes and the spinous processes. As you go down spinous process, they will be tilting down and down and down, right? From the top. So on the top, for cervical, so the spinous processes, they will be like this. But as you will go down, their angle would change. Similarly, the transverse processes will become stout and more powerful.
Yes, sir.
Obviously, ribs are connected to the transverse process at the posterior end. Yes, because anterior end it is connected with the mandibular sternum. CSF, we won't be discussing. Cerebrospinal fluid. Wait. You come. I'll see you. Now see, this is dead lateral. Here is the spine. Right? We have removed the rib so that there is no confusion. And that's the transverse process. Right? That's the transverse process. So can you see over here the area which is very shiny area, this area, which is shiny area as compared to this is very dull area. Right? So over here we need to see three things. One, this is the transverse process, and that's the point where the costotransverse joint will be formed. Then the ribs and with the body, they are connected over here. So that is with the body. But another thing, here is one vertebra. This is one vertebra. Here is second vertebra. Here is second vertebra. So when two vertebrae they meet, they form this space, and that is called as the intervertebral foramen. Intervertebral foramen. See, this is the lower end, the below vertebra. That will be going like this. And here the intervertebral foramen. It is from these intervertebral foramen the spinal nerves will be coming out. And why the spinal nerves? Because the top view here is this, that is the space for spinal cord. So from brain right? Spinal cord is going via these foramen, vertebral foramen, right? All the way spinal cord is going, and through these spaces, to these spaces, to these spaces, to these spaces, see over there more clearly. The nerves would come, and these nerves will be forming the plexus, and then they'll be supplying the entire body. So here, intervertebral foramen is the word, and the spinal nerve roots which will be coming out. Now, in nerves, there is anterior root, posterior root, right? Then there will be gray matter, white matter. There will be some nerves which are for, say, sympathetic activity, parasympathetic activity, motor, sensory nerves, right? Some are mixed. They are making the tracks, right? Then there are ganglion, preganglion, and postganglion. They are like relay station. Every structure is into this area. So that's why this is considered as pretty complex area. But once you understand, we'll be having the entire picture. When we'll be studying the spine, we'll be studying the spine in a single shot. From cervical, the moment it comes out of the, from foramen magnum. Foramen magnum. Magnum means big. Foramen means whole, right? So it is foramen magnum. So here, where is it? It is straight away onto our head, right? So if you take the head out, and if you see that there will be big hole, through that hole, the above, this is the cerebrum, then there is midbrain, pons, medulla oblongata, and the spinal cord. So that foramen magnum is over here. Skull. So this is the area. This area is pretty crucial. If someone gets head injury and if there is hemorrhage, so blood starts getting collected. This is a fixed space. It cannot expand. If it cannot expand, that means brain will start going into the state of compression. When the brain is getting compressed, brain will try to go out because the pressure is increasing. It is called as the raised ICT. Here I is intra. C is cranial. Cranial means head. Intracranial tension. So when it is expanding, so brain will try to kahin pe jagah hai to main bahar bhag. So this is the foramen magnum. Foramen magnum, through that brain will push those structures out. Now the most important structure over here is medulla oblongata, where our respiratory center is there. So when that thing starts compressing, that person feels sleepy. And then as the compression increases, it leads to respiratory arrest. So that's why all these things are important. How the intracranial tension, because when pressure is increasing, it will raise the blood pressure. Now classical thing, it will raise the blood pressure. किसी के सामने football love baby, right? Short practice of surgery in which there are cranial injuries. Someone is hit by a football, right? But he became unconscious because that was the first impact, cerebral concussion, first impact. But then he gained consciousness. He came back. He ate something, but he was not feeling like eating anything. There was a bit of nausea. So he thought, let me go to sleep. That person went to sleep and he never woke up. What really happened was that there was injury, right? There was hemorrhage. That blood started getting collected. There was raised intracranial tension. Blood pressure was rising. But at the same time, there is nausea. Because retina is affected, right? Retina is the direct connection to the brain. So there is, say, all those sorts of, not the blackout, but blurring of the vision. Person won't feel like talking. Why they remove small portion of the skull temporarily? Yes, it is called as the bar hole, right? I'm coming to that. So when the pressure is increasing and person goes to sleep, now there is no defense mechanism. The compression keeps on increasing, brain goes more into sleep, and then silently, as the medulla oblongata is fully compressed, breathing stops and game over.
Sir, there is no prevention of this.
There is. That's why the history is so important. That it has happened 5-6 times. One of my, he is into Bollywood. And he called up to Sarji, aisa hua. I said, immediately go for it, right now. अच्छा, when it happened, he said half an hour back, बच्चा बेहोश हो गया, but अभी तो खा रहा है. I said, immediately do the video call. Right? I asked him 2-3 questions, but his answers were vague. I said, rush to the hospital, take him for the MRI. And there was hemorrhage. The thing is, chances increase after multiple. The thing is, its treatment is like literally like a drill machine, right? I'll show you. There is one area, right? And it is drilled. And the catheter is put and the blood is drained out. The moment it is drained out, immediately that intracranial tension is released. That patient can survive. What about that broken bone, etc.? All those things, they can be repaired. The idea is to save the life. That is crucial. That decision, right? That is so important.
Sir, migraine is for the same reason.
Migraine is totally different. Migraine is totally different. There can be multiple reasons of migraine, because migraine can be triggered even by the chocolate. We'll see that. So here is a complete picture all the way to the spine, to the vertebrae, right? And then we are watching all these ribs. Here it is.
Sir, why some people while doing 24 hours fasting, they get starving migraine, right?
That is because of the lack of glucose.
Okay.
Hypoglycemia. So it is nothing but hypoglycemia. But
Yes.
as you sustain that thing for some time, so then the ketone bodies come into picture and then they supply to the brain. Then the brain is very active. That's the reason first day is difficult, second day is quite okayish, third day no problems. Right? Because then the body is fed with those ketone bodies.
Yes.
So here it is 1, 2, 3, 4, 5, 6, 7, right? The true ribs going all the way, 8, 9, 10, they are landing on the pathway number 7, 11, 12, floating. All these, they are from your practice and understanding.
Excuse me, sir. Sir, what is the main reason for brain stroke?
We won't be able to discuss right now, but we won't be able to finish the topic. All these are pathologies. Otherwise, stroke is what? Whenever there is lack of blood supply. It could be because of embolism, it could be because of any of the accidental injury, local injury, focal injury, maybe it can be because of some tumor. If benign tumor is there, it is just giving compression. If it is malignant, malignancy, it can spread across the skull. So many reasons. So this is for the practice cranium. Just give me a second. So cranium, facial bones, mandible, cervical vertebra, rib number 1, clavicle, rib number 2, there is manubrium, then sternum and the xiphoid process, just for the practice. Here is another bone which you can feel very prominently, that is the hyoid bone. Right? Hyoid bone.
Is that a floating bone?
Yes. It is Adam's apple, right? Adam's apple, which you can feel in the neck. Just for the conceptual understanding, that's the skull, smiling skull. Okay. Now comes first, let's see the skull. Here is the skull. The skull is made up of so many flat bones. Right? So this bone, that is the frontal bone. It is in front. What else? This will be the frontal bone. This bone this bone, like this, it is parietal. Then the bone which is on the back side,
Occipital.
occipital, very good. It's called as occipital. And then this bone, right? which is-
Temporal.
Temporal.
Now, in between these bones, they are called as the sutures. This joint, right? Irregular structures. Right? Here, over here, over here. They are called as the sutures. So this is the area where four sutures meet, four bones meet. This is the parietal which is coming over here. Here is the frontal. Here is the temporal, right? And over here, you'll see it in facial bones. So that sphenoid, when it is meeting over here, so this is leading to very important area, and that thing is called as the pterion. It's called as the pterion. This area. So pterion is that area where, which is the weakest area of the entire skull. That's why in martial art, when they give a chop, so when it is hit over here, right, this breaks easily. Not only that, just underneath this bone, there is branch of middle meningeal artery. Now that artery, it is embedded into bone. What I mean to say is, this is the artery. This is the artery. It's like this. If it is broken, no problem. It has got capability. It has got those muscles, circular muscles. They will compress it. It will be closed. But when the artery is embedded into the bone, right, it won't be able to close. It remains open and it keep on bleeding on and on and on. So that's what we'll study in more detail. We'll be discussing the head and neck. But this is the importance of pterion. This is the weakest area. That's why when the lathi is put over here, when the chop is put over here, when it is hit by, say, football, cricket ball, right? In cricket also you must have noticed, when this area is hit, then immediately the doctor will come and will examine neurologically. Helmets, they have got the extra protection to save the pterion. This is our top view. We are watching from the top. So here, this is anterior, right? So this is the nose. So that's the anterior, and this section, this area is like crown, so we call it coronal, right? So this is what we are talking about. This one. That is the coronal suture, all the way from one side to opposite side. Coronal. That's the coronal suture. We are talking about suture. Suture means between the bones. Right? So coronal suture will be between the frontal bone and on the top, here the parietal bone. Right? Makes sense? The frontal is in front. That's the parietal. It's coronal suture. Then over here, this is the occipital bone. You see this part, this suture, right? All the way that suture is going. It is called as the lambdoid suture. Lambdoid suture. And then there is one suture, when you watch from the top, it is going all the way like this. This is none other than sagittal suture. Sagittal suture. So we have got three major sutures, right? Three major sutures. Coronal suture, sagittal suture, and on the back side, it is the lambdoid suture. On that day, we were talking about those soft areas. They are called as the fontanelli. They are called as the fontanelli. Fontanelli, there are two. One is the anterior and second is the posterior. So this is the anterior fontanelli and this one is the posterior fontanelli. That's anterior and this one is posterior fontanelles. So these fontanelles, these are the area which are when you push, so you can touch the brain directly. They are the soft areas. Gradually they fuse, and that's why Sometimes when on forensic science, forensic medicine, you come across the skull. Then from that skull, you figure out that what is the age of this, what must be the age of this kid when he or she died, right? From the closure of fontanelles. So for that age estimation, right, I'll show you the entire formula. I'll give you the entire formula that which bone to be seen one after another. So here it is the frontal. Right? This is for practice. This is frontal. Then the facial bone. This is the maxilla, right? Common test. And when there is common cold, we press over here, we get the pain over there, maxilla. Maxilla is, remember it like it is connected to your teeth. So that's why whenever there is some teeth problem, right, you get pain over here also. So this is maxilla, very important. And in that, there is sinus, maxillary sinus. The way there is over here frontal sinus. There is frontal sinus inside. So if you break this, then you find air pockets. There are metopic sutures, yes. Right now, we are just taking major sutures. And then the maxilla. So in this also, there is maxillary sinus. Then this is zygomatic. That prominence on your cheek, right? That is the zygomatic. This is again maxilla, again zygomatic for practice. This is the side view of maxilla. This is side view of zygomatic. Then this was the sphenoid. Sphenoid is one of the very beautiful. This bone, it is like a bird. With the body, and then there are small bones, and the that is sphenoid. But it is only seen partially. When we cut the skull and then we dive in, then we will be watching how beautifully the entire sphenoid is lying. So that is sphenoid. This, we talked about temporal and intemporal. The crucial component is external acoustic meatus. Because from this, the inside, when we cut, the entire canal is a bony canal. So there is middle ear, then inner ear. So there is an in-between canal which is into the bone with all those small ossicles, Milius incus. This is parietal, easy to follow, and this is occipital. Now there are two important processes which you must remember. One, you'll be able to feel just behind your ear touch, right? A very prominent bone which you just can't forget. Very prominent bone, that is the mastoid process. Styloid process, don't even attempt to feel because it is very deep and there are 6 muscles attached to this Nannisi channel, right? Thin styloid process and then those muscles, right, they're getting connected. So it is surrounded by muscles, not very easy to feel. And if you try to press just too hard, right, there are important structures. There are important structures which are going on to the neck. Unnecessarily, they will be compressed and we start getting pain. Mastoid process, you feel. Styloid, don't try to feel. It's very deep. I agree. This is a styloid process and there was styloid process into the wrist, right? But when we say in the same region, we won't be using that. Over there, it was medial styloid process and lateral styloid process, right? Over here also, there will be right styloid process and the left styloid process. Here it is coronal suture, right? Lambdoid suture and the sagittal suture. So these are the 3 sutures. This is frontal, this is frontal. As such, right frontal and left frontal, in between it is called as the metopic suture. But in many of the cases, metopic suture might not be present. The whole frontal is one. Now we have opened a space, right? Yes.
Is frontal or coronal same?
Your voice is breaking.
Is frontal and coronal is same, sir?
Frontal is O, right? This is frontal O. And this one. And coronal, it is a suture. Suture means junction between two veins. I'll just remove this. See, can you see the ragged line? Can you see this?
Yes, sir.
Right, that is a suture. That is a suture. Clear?
Yes, sir. Thank you.
Now we have opened a small window. So it is like this much of the skull. Right? Just cut this much and we open it. So now we are watching inside the skull, and this all these channels, big gaps they are seeing. Big gaps. That is where the blood vessels will be there. Right? So you can imagine how big blood vessels are going. And in fact, it would be like when the carotids will be going, internal carotid, thick internal carotids they will be going. Then on the back side, there is vertebral artery, right? Vertebral artery. And then they will combine, and then that will go. That is how it will form what is called as the circle of Willis. Circle of Willis, complete supply to the brain. So all these channels, they will be filled with blood. Now see, these are all the venous sinuses. They are called as the venous sinuses. Till now, we have not even given that much importance to veins. In brain, it is not so the way the arteries are going exactly when the blood is coming back, it is coming back by the same name of vessels. They are different. This is completely different. So in case of veins, it will be making such venous sinuses and will make the whole network. And for arteries, there is circle of veins. Now here is the occipital bone, as we are watching it from the back side. Right? See, there are ridges. These are the ridges. These are the ridges because powerful muscles they were getting connected over there. Right? The entire ligamental movement. Right? This nape of the neck is formed. So that nape of the neck, nape means this posterior portion, right? Posterior portion. So that is powerful, so that otherwise head would fall, right? But then that pulls and keeps the head up. So that is the nape of the neck. Those who are into gym, right? And even in martial arts, there is like a headband. Right? There is like a headband, and opposite side there is screw, and then you hold yourself, and then you hang the weight, and then you do this exercise. Right? So what are you trying to do? You are trying to make your neck strong, so that boxers they usually do. So even if there is a power punch, but the neck holds. Otherwise, the neck would be thrown back. Right? So here it is.
Sir, F1 racers भी.
Pardon?
F1 racers.
F1 racers, yes. Achha. Now we have removed the skull. We have taken the skull out, and then we are watching from below. Right? So this is the head we are watching from below. And here it is. That's the foramen magnum. And in foramen magnum, midbrain, pons, medulla oblongata, spinal cord. This is the foramen magnum, in which the spinal cord will be down. This is the real skull. Here I would like to show you two things. This is C1 and this is C2. What you have to watch is, can you see this? Something like this. Inside, if you
Atlas and axis.
that area is called as the dens. So the head rotation, what it is occurring, it acts as a pivot. Right? So C2, but C2 vertebra, they are like ring vertebrae. In this vertebra, there is no body. It is the C1. In C1, the body is here. In this case, there is no body. This is C1. And when it comes to C2, coordinates, living on extra production. This is the dense. So that's the C1 and C2. Atlas axis. And that's why this joint which is formed, this one. What name should we give to this joint? If above vertebra is called as atlas, this one is called as the axis. What name? Atlantoaxial joint. Correct?
Yes.
Atlantoaxial joint. These are all spinous processes. And in between, there would be IVDs, intervertebral discs.
Sir, there aren't any transverse process in cervical spines.
Which one?
Transverse process.
Here is the transverse process.
Sir, in C2 or C3 there.
C2, now they are like very small. They'll become bigger and bigger as you will go down.
Okay.
Here it is. See how this lambdoid suture will look like. Look at the lambdoid suture. Right? So big, so irregular. That is the lambdoid suture. So oral suture, lambdoid suture, and here also sagittal suture. Oral, sagittal, and this lambdoid, and here it is. That's the mustard process, and in between you can see the styloid process, but because all the tissues. Now this is a cut section. This is a complete cut section. Exactly from the sagittal plane, things have been cut, and then we are watching it. On CT or MRI, you'll be watching the similar image. This image is shown so that you should be able to identify the major structures. So here it is. That's a brain. That's a brain because this is a real sample, the real cut. So the brain will also be seen. This is where the brain is. This is the nasal area. Feel this hard palate above, right? The hard palate. But as it goes back, it ends in soft palate. Right? Hard palate, and then you try to take the tongue back. Now in yoga, something what they say, khichdi mudra, right? That is for the very high level of meditation. So in that, the tongue is to be taken back and try to touch this soft palate. Not easy. It's not easy. And then you close your eyes and try to focus. What they say that it forms the complete circuit. I'm not an expert in that, but some things they do matter. Say, when we do meditation, we sit like this. Okay? So this is very, very important for the student. And everyone is student for whole life. So when you do like this, right? When you do like this, so this completes that part of the circuit which is taking care of the knowledge system of your brain. Yes, that is the occipital condyles. Yes, you can watch. This is the occipital brain itself. That's right. So here is the hard palate, and that thing, as you try to feel, push the tongue back, you'll be able to feel the soft palate. And in between this is, in below it is the tongue, right? And these are the muscles of the tongue and the nasal concha. The nasal area is thrown into folds. They are called as nasal concha. Onto the lower limb, lumbar vertebrae. From lumbar, this is the innominate bone or hip bone or the pelvic, one and the same thing. Over here, we want endurance, the power, and we want power. And the endurance, that is for the legs. When we say endurance, okay, this we are deviating slightly. Stop. This portion, this is the acetabular cavity. It is called as the acetabular cavity. So this acetabular cavity that is blue, and it will hold the head of the femur. See, almost the entire head has gone inside. The purpose is stability. And then comes femur, tibia, tibia. But the kneecap is called as the patella, which is right in front. It's called as the patella. And then we have got the tarsals, metatarsals, and phalanges. Same style. There is stability. There is deep acetabular. Deep acetabular. And that's the head. This is sacrum and this is corpus. Last batch said that this looks like a smiling. Yes, it is.
Yes.
Right. But this is innominate, also called as the hip bone. It has got three parts: ilium, ischium, pubis. Ilium, ischium, and pubis. Ischium, this is the area on which we sit. Whether it is chair or it is straight away on the floor, but we always sit on ischium. So there is an ischial bursa also. Got it? Ischial bursa, so that it is handling the pressure. Then the anterior area where opposite sides they meet, that is the pubis region. So this is the pubis. This is the acetabular cavity. See how deep. And rest is this area. So ilium, ischium, pubis. So this is where two pubic bones they meet. This is one bone, this is second bone. That's where they meet. And joint is called as symphysis. So this is pubic symphysis. Now when you put your hand like this and put it in style on your waist, when you put it like that, the entire ridge is nothing but you are feeling your iliac crest. That is the iliac crest. When you put it like this, and so that is your entire iliac crest. The end of this crest, anterior end, this is anterior. So this is the anterior end. This is the interior end. This anterior end is anteriorly so anterior. This is on iliac bone, yes. It is spinous pointed, yes. And it is superior to, because there is something like it. So there is inferior iliac spine also, and that's why it is called as the anterior superior iliac spine. And from that spine, there goes one ligament, and that is called as the inguinal ligament. Inguinal ligament. Inguinal ligament itself is a huge topic. All the hernias, people get hernia. So there are direct hernia, indirect hernia, all because of the formation and structure of this. This pubic symphysis, that is where the external genitals are connected. And then this is the area where in case of female, the uterus, and on both the sides, there are fallopian tubes, and then it is connected to the ovaries. Femur being the longest bone. Focus is on now head. Then when you see that there will be a depression, right? Small khada, small depression. It is called as the fovea capitalis. Fovea means a small dim inside. So that is fovea capitalis. This is where the ligament of head is connected. So this is where the ligament of head is connected. That head will be carrying one artery. That artery is called as the nutritional artery. That is nutrient artery of the head. We say that these are big prominences. See how big prominences are. That's why we call them greater trochanter and lesser trochanter. So this is the integral. For some reason, if this artery is cut, then that leads to avascular necrosis. Necrosis means sarjana. Avascular means because of the lack of blood. So that is called avascular necrosis. Now this is a posterior. See in posterior view, you can see things much better. This is the greater trochanter. This is like a lesser trochanter. And in between trochanter, so we'll call that again intertrochanteric crest. Intertrochanteric crest. Then, because this is posterior view, there is gluteal tuberosity. This is see such a rough area. Gluteal tuberosity, because gluteal muscles will be touched. This is knee. That's the patella, the kneecap. That's the kneecap. And then we have got lateral condyle, medial condyle, tibia, fibula, all. Tibia.
Sir, in upper limb there are epicondyles, right?
Epicondyles, here condyles.
Okay.
Epi means small. And these are the real bones separated. Now, over there were condyles. As you come down, right, in your foot, you will be able to feel immediately lateral and medial malleolus. Those prominent, when we wear the socks, right, those prominent things on both the sides, they are called as the malleolus. We find lateral and medial malleolus easily. No issues. Then comes one big thing. Now we are talking about tarsals. So those tarsals, see this portion, right? It looks like our palm, long bones. They are called as the metatarsals. And then we have got these are all phalanges. So here we have got the metatarsal and these are the phalanges. This one is the big toe. All these areas, they are the tarsals. In tarsals, here this is how we see from the side view. Heel pain people get. That is because of this calcaneum. This calcaneum, very big bone, but it is forming your heel. So that is called as the calcaneum. From calcaneum, you should be able to see a very tough structure.
Mm-hmm.
A tough structure. So that is where it will be connected to the calf muscles. This is called as the tendo-Achilles. Tendo-Achilles. That also called as the Achilles heel. There is one very interesting story behind it. I will discuss that. So think it like this, that this is the tibia, right? That's the tibia. This tibia is landing on another bone, which is the talus. This is the talus. This one is calcaneum. Then in front, this is one more bone, which is called as the navicular. So here is big bone, which is forming the heel. Then there is talus, on which he is forming the joint, and this talus is connected to navicular. That navicular is connected to these cuneiforms. All those things, cuneiforms. We have got the cuneiforms. There are three cuneiforms: medial, lateral, and intermediate.
Sir? Some people have flat like flat feet,
That's
so they don't have the arc. So that
This-
is because of navicular.
no, it is not because of navicular. It is like these bones are strong, but in order to keep the arch, the powerful muscles they should really pull it. But if those muscles are not powerful enough, then that will lead to this structure would collapse. This structure would collapse. Now, this is the best figure where you will be able to see everything. Here is the calcaneum. See the big bone, right? That's the calcaneum. On the top, this is talus. That's the talus. So from top, the tibia is landing. This is the tibia. Tibia is landing on talus. Tibia is landing on talus. This is the tibia. To talus. From talus, the weight is transmitted to calcaneum. Because calcaneum is the heel. This pressure is now transmitted forward. So this we talked about this bone, right? Navicular. And then we said navicular is connected to 1, 2, and 3. They are called as the cuneiform. Right? Medial, lateral, and in between is intermediate. And then there is another bone which is connecting calcaneum to the phalanges. That is called as the cuboid. So as such, there are only 1, 2, 3, 4, 5, 6, 7. Just same 7 names. As such, 5 names. 1, 2, 3, 4, 5. Calcaneum, talus, over here, navicular. This is medial, intermediate, and the lateral cuneiform and the cuboid. All these are metatarsals. Metatarsal means they'll be forming actually the foot. And finally, the phalanges, the other fingers. See the real ones. Again, lateral view gives complete idea that this is the tibia which is landing on talus, transferring to calcaneum. And then we have got this navicular that is in between the cuneiforms. This is for the practice. Again, complete mark as we are watching from the top. Don't confuse. This is calcaneum, then the talus, navicular, connected, uniform, medial, lateral, and intermediate. These are the metatarsals, and these are called phalanges. There, that's a cuboid and calcaneum. Right. Again, for practice, this is the taken apart. We have just moved the talus to show that, see, this is the calcaneum, which is purely forming the heel. And then this is tendoachilles. And that's the talus. There would be the joint formation between calcaneum and talus, and on top of it, there would be tibia. Right? Then talus will be connected to navicular. And then, so that's how, when you run, right, everything would matter. The muscles which will be working and how to maintain this arch. This is the tibial arch from here. So this was the question. Which side it is? Right side knee or left side knee?
Left.
Right side.
Some say right.
Right side.
Right side, because the fibula is on the
Right
left
side.
side.
So tibia is where?
Left side.
Right
Fibula.
side.
Fibula is on the left
Right
side.
side.
Is medial or lateral?
Lateral.
Tibia is
Medial.
medial. Fibia is
Medial.
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 And fibula is lateral.
Fibula is lateral. So if this is lateral, this is medial. So in your body, this is for right side or left side?
Left.
Left side.
Left
Left
side.
side.
Left side.
Left.
Right? So such questions they can be asked in exam.
Sir,
Hmm?
so is navicular boat-like?
Navicular?
Is boat-shaped? Is it boat-shaped?
Is it boat shape?
Boat-shaped.
Yeah. It is quite boat shape. Yes. So here, same bone is shown in full length. So that was like upper limb, lower limb, thorax, abdomen, pelvis. This is the order in which we should really discuss. So that's it for today. Save it. All right.
Sir, in lower limb, the
Recording stopped.
large bone is on the medial side and the small bone is on the lateral side.
Correct. Because see, big bone is always connected to your thumb, whether upper limb or lower limb. In upper limb, radius is bigger, connected with thumb. So over here, radius is out. So in upper limb, just we say big bone. In case of upper limb, it is radius, and radius is on outer side. Or we call it lateral. Correct? In case of lower limb, in anatomical position, our thumb is medial.
Medial.
Inside. So this is tibia, which is a bigger bone. So this is medial.
Okay. Sir.
Easy.
Hello, sir.
Yes.
Sir, should we call the greater trochanter superior or lateral or only superior?
As such, greater trochanter is superior.
Okay.
But because they are, there is not much of the difference. Right?
Okay.
They are almost at the same level. They are at an angle. But because the size really matters. See, usually what would happen when we say superior or inferior, when they both are of the same size, and then there is clearly there is some demarcation point that yes, above this and below this. So yes, you can say greater trochanter and lesser trochanter as superior and inferior. But because their size matters, so that's why they are called as the greater and the lesser. And greater, when you wash on bone, right, it will look like a big, tough structure. Lesser is bit of sheriff.
Okay, sir. And sir, the ridge is called intertrochanteric crest. Something. Yeah. Okay.
Crest. Crest is once again, right? Ridge is delicate. Crest is powerful.
Yes, sir. Thank you, sir.
All right. So thank you so much.
और सैटरडे को टेस्ट होने वाली है
Sorry, again repeat कीजिए क्या बोले?
सर सैटरडे को टेस्ट होने वाली है नहीं होने वाली है
आप बोलिए रखनी है कि नहीं रखनी?
रखना है सर.
रखना है सर.
Definitely will be.
So
And
what is the syllabus?
Syllabus, whatever we complete till Thursday. This next time, we'll be meeting day after tomorrow. So we'll be having one more topic. So everything right from the beginning till end, that is the course. Every time we'll be following the same pattern. So no confusion. Whatever is studied till the last day, that is the course.
Sir? Hello, sir?
All right.
MCQ base or written base?
Yes.
Is it MCQ base or written base?
MCQ.
Okay.
Initially, it will be MCQ and it will be very easy. It will be very easy.
So, how to diagnose nerve compression?
How to diagnose nerve compression? That is, diagnosis is everything would come into picture. Inspection, palpation, and then history and the radiological diagnosis. You have to watch that how is the patient tilting on one side because he is having pain, that's why he is tilting. Then palpate. Palpate is when you feel that where the exactly the pain is, because there are specific areas where that pain will be transmitted. History is important. Is there any history of fall or any injury, stabbing, lathi, and then the radiological examination where you are ruling out that where exactly the pathology is lying.
So nerve compression always seen in an MRI, never seen in a CT scan.
CT scan you can see, surely CT scan. But when you use the MRI, in MRI you will be able to see that what is the condition of those disc spaces, discs. So if there is desiccated disc in which the water content has been removed immediately from the T2 weighted image, you'll be able to figure it out and you'll be able to diagnose this thing and you'll be taking radiology. Right? So I'll show you the CT scan of a patient and same patient I'll show you the MRI on both the things, T1 weighted, T2 weighted, short T1, long T1, short T2, long T2, all those things you'll watch and you'll be able to diagnose. It is very logical, so no big rocket science. And once you know, then throughout your MBBS, you'll be able to see the MRIs in a very different perspective.
Okay, sir.
That's why for almost, say, 10 days,
Excuse me, sir.
3 or 4 sessions, they will be purely on radiology. Yes, any question?
Yes, sir. It's Kranti, sir. So you said joint between the phalanges and metacarpals is called as metacarpophalangeal joint, right? So, sir, can we refer it as nuchal joint or nuchal? I don't know how to correctly pronounce it, but it's nuchal joint.
Knuckle, na?
Knuckle. Yes. Yes, sir. It's okay, sir. Thank you.
Okay, so take care.
Hello, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Bye.
Thank you, sir.
Hi, sir.
sir.
Thank you.
Excuse me, sir. So it's bit out of syllabus, like related to digital. I ordered that Vacom board. So which app you are using for notes right now?
This is Jawboard PDF. It is Jawboard PDF. But I tell you, don't buy this. Because see, it's paid version that is pretty costly. Right? And every year you have to pay for it. I mean, आप सब घर के हो इसलिए बता देता हूँ. I have hacked it and I have taken its API file in such a way that I don't have to pay anything. But I won't advise it. It is pretty costly.
So then any particular app you will suggest?
You search for it and I'll send you many of them, so they are free.
Like I'm using OneNote now. Like
OneNote is very good.
And external, otherwise Notability from both of them. Like you know anything about them?
Notability.
Yes.
GoodNotes is good.
GoodNotes is good. Yes. GoodNotes.
Sir, even Cola Notes.
Which one?
Cola Notes.
So I have not used others, but yes, you can just try and test which one is comfortable and suitable. But so many of them are available. This is so very professional. That's why they charge so high. They charge in the range of about 15,000-20,000 rupees a year. Won't
Oh
advise.
my God. Hello, sir.
एक बार पैसे भरे थे, then I finished it. उसके बाद कभी नहीं.
Hello, sir. Can you send today's updated PDF in the drive? Because new markings are there today, right?
Mm-hmm.
That's right.
That old PDF that would be updated.
Okay.
Notion app. Someone else said Notion app. Speak good. I'll also check. Notion app. All right. So take care and see you soon.
Bye,
Bye, sir. Bye, sir.
Bye, sir. Thank you, sir.
Bye, sir.
Bye, sir.